cases, how many? There's no living. Anything could be a short case. Huh? Anything. Anything. Even a wound, cellulitis, amputated toe, gangrenous toe, anything. Just short case. So, short case, you all have to practice as much as you can. You ask 22nd batch, I told them, your spinal cord works there. Nothing goes to your brain during short cases. So if it is in your reflex arm, you will perform well. You will forget to take the torch out of that day. Take my girl. So practice as much as you can. Short cases. Right? Long cases, you make sure it is covered up, but what are you going to do? So tell the GUSR, there are 2 GUSRs, they will cover up hematuria and wound. Others, that's our answer, SRs will do. And shadows, they have to come for the night round every day. And your registrar night round should teach you. They don't teach, tell me. If you all are here, you all have to learn. Somebody has to teach. I don't believe in self-learning. It should be there, but I don't believe in total self-learning. Very later, I don't have to. So, right. What do you all want to do today? What do you want to do? Painless or painful?
Here bleeding.
Painless.
Here bleeding.
Will be too much, no?
Here bleeding.
Malignancy, spalvitas, local what is the exceptional batch?
How is it?
I figured it is exceptional batch because you all have 11 common distinctions. That is 40, that itself indicates this exceptional batch. As far as I am concerned, that is highly exceptional. I don't go by that. I will judge from today onwards. No favoration, no grudges. Judgment starts today. No preference, no gender preference also. So shall we do pain full part? Do you have a history?
Yeah.
Patient with cold stone disease?
Abdominal pain.
There are patients now.
Abdominal pain is common. Patients are
DRC today?
Abdominal pain is common complaint.
Female patient, your patient. Does she have jaundice? Head. Sit. You can talk loud. And you all have to start doing MCQs. Now what? Within the appointment, finish your MCQs. Clarify it out. You will trouble us. Anytime. First time, and call us, text us, academic stuff. and also if there is any problem during the board stay. How will I walk harassment because the board staff is out of the let us know. If you get obtuse in this situation, you have to go down to 24 and talk to the nursing staff, get the ABPI and come up. Because ABPI, the handheld doctor is there in they give you 8 and if the pay is there to 24. So if they don't give, let us know. We will do something. You are able to hard on good determinant in that. So here is the box and harassment का बोलना let us know. Ada क्या है पार्टनर के बराबर भी करा है so don't create issues. Right. Okay. छाता नहीं ना. ऐसी है तेरे But at the exam, you can't tell like that. You have to go back to the percentage of it and start from that. You can't say admitted as requested for AR, APR, thyroid ectomy. That is not a percentage complaint.
2 weeks back, she had an episode of abdominal pain. The pain was not localized to a specific area. It was spreading all over the abdomen, which was a sudden onset pain of burning size. It radiated to the lower back and it was associated with sweating, fatigue, nausea and jaundice.
Where was the pain initially? All around that? Typical feet. So never localized. Yes, I would say.
And she had about 5 episodes of vomiting as well, which consisted mainly of food and there was no blood stains. The episode was associated with lunch. The pain occurred just after she had her lunch, and it was a severe type of pain, and she did not notice any accelerating or healing factors.
What has she taken for lunch?
Yes,
Was it a fatty meal or just normal diet? What is the relevance? Is it important?
Yes.
Yeah, it is. Usually aggravated by fatty meal if it is related to the biliary tree. Okay.
for this episode of pain, she was taken to the Gangpa hospital where she was treated for gastриtis. And on 19th, again she had a similar episode of abdominal pain, to which she was taken again to Gangpa hospital, and from there she went to Narayan Army Hospital, where she had undergone an ultrasound scan and was diagnosed with gallstones. She had not undergone any
She told everything, no? Very educated patient. So you can tell. The patient says yes, you can tell, no problem. But you can't go through the records. At the exam, you will not be given records. You will be only given patient and a blood pressure, 60-manometer, that's it.
She did not have any similar episodes before these 2 episodes, and she did not complain of any pruritus, and her past medical history, she was diagnosed with gestational diabetes.
Anything else in the history of the presenting complaint? No, you said this patient has gallstone disease. She did not have similar episode. Any episodes of obstructive jaundice? So this episode she has obstructive jaundice. Does she have jaundice?
On 19th, she had.
Cure. One of the jaundice and what else? She has noticed discoloration of eyes.
The hands,
Okay. And what else? What are the features of obstructive jaundice? What are the cardinal features? You said it. What?
she had
Stools?
stools or no?
No. And it relieves spontaneously, is it?
She did not have any fever, itches or rigors, no cough or dyspnea. There was no lower growing pain, any
partner? Examination. Yeah, you are you work. Then, so you are going to go to the exam with her. Then, no excuse. Today is the first and the last day. Okay? Because history has to be independent. Then, me, then if the patient you know, then me, or then I got to me. Exposure so you have more patience. Okay? So some of the bargain and me. Then what? It will do that. It is the last day, huh? So next day, you can't regret it. Tamara share karaga be careful. Then it has to be independent also. Sometimes let out the other than a person. Interview let out. May I come? May I come? I have a person without I would kiss her. It has to be two independent. This is only to increase the exposure, not to reduce the work. Okay? Some message is given and this appointment is very linear than the next appointment. If you can't get through this appointment, you can't get through next appointment. For sure. 100%. It's very tough. Next appointment. All this time, people used to call, from heaven to hell. I don't know whether it will change for you all. From surgery to medicine of time, that's the rotation. Medicine, genomes, medicine, surgery, genomes, and so always it's heaven to hell. Then I don't know with exceptional, I don't know. Yes, exactly. So that is, and incorrect is no jaundice. No repeat it. Anything significant? Anything positive? Any positive finding? Any report negative finding?
Not even much.
Was there right mitochondrial masses? No pathological Murphy's sign? What is Murphy's sign? Where? Where the intellectual process, where you feel the fundus of the gallbladder, and you ask the patient to breathe in and out. In inspiration, that is Murphy's sign. How do you spell it? Examination at finals, they ask certain things just to see whether I have read it in a book. At the time, typically, summary. Have you written summary? So that's another message. Whenever you take a long case, you write your summary. Because at the exam, they might not ask you history, especially those who are at the latter part. Vikram Singh, examiners are fed up. You have to. Sometimes they ask only the summary, just give me a summary. Because they know the history. Sometimes they do that. So if you don't have a proper summary, if you don't know how to write a proper summary, then you are in trouble. So how do you summarize these patients? The 7-year-old mother of 3 who is a diabetic patient presented with 2 weeks history of vague abdominal pain with radiation to the back, increase after meals, associated with transient episode of jaundice. She does not give a history of pharyngitis. On examination, she is not dictating. Abdominal examination, something normal. That is the summary. Maximum 5 sentences. Okay? That is your summary. So that is the other message for you all today. Look at my anybody can work harder edited on no problem. Our classes are not compulsory. These out of jokes may consultant class or ignorant class. But SR, yes, you all can go. Especially if you want to PEO, the other one or whatever. If the females are small, that they can't hold on to the block for English, so they have to go again to sexist. Yeah. Okay, so that is the summary. To get a patient like this, now let's say patient did not say about the ultrasound scan and the gallstone disease. What are your differentials? Where was the pain severe? Abdominal volume granule movement can then try to localize it. You will realize this when you become house officer. You will love to do male ward house officer 3 months than female ward. Even females, they come and say, you ask. It's very difficult to come to diagnosis. In style. Not in drawing. මෙතන කැක්කුමේ කොන්දරත් යනවා. පාත් තුනම අඩු වෙනවා. කෙලින්ම පැන්ට්‍රයිටිස්. Yeah. So hotel में වැඩිපුර කැක්කුමනේ. එහෙම නැහැ. කිව්වරම. So could be, sometimes even colleagues, they don't know where the pain is coming from. It's very severe. Okay. It's a severe abdominal pain. Does it gradually progress? Sudden onset. Sudden onset pain. How long it lasts? So it's relieved by analgesics. Relieved. Has it come to baseline or just chronic pain there people? The get for that can keep up. No, relieved. So according to you, it's a colic. What is a typical colic? It goes to a maximum and then it comes to the baseline. That's a colic. But biliary colics are not true colics. What are true colics? Uterine colic. More than the intestinal colic is the true colics. That you know shoot up maximum and then it comes to the baseline. Biliary colics, උඩට යනවා ගොඩාක් වෙලා ගියොත් අඩු වෙනවා. Baseline pain එක කියනවා. Where do you get the biliary pain? Abdomen has how many quadrants? 9. Where do you get this pain? Epigastric. So structures derived from foregut, the pain is referred to the epigastric. Structure derived from the midgut, pain is referred to the central part. Structure derived from the hindgut, pain is referred to the suprapubic. That is the norm. Don't get away with the idea, no, gallbladder, it's here, so it has to be RHC pain. What is that? RHC is not right? Hypochondria. Don't say patient has hypochondriac pain. That is wrong term. Hypochondriac is psychiatric. Not hypochondriac. Hypochondriac. Right? It's a psychiatric disorder. Hypochondrial is the correct term. So it is epigastric. May or may not have a radiation. May or may not have a radiation. And it's not a typical colic, long lasting. When stones are in the common bile, now the reason for this colic is the tubular structure getting obstructed. Ureter get a colic because it's a tubular structure. Intestine also the same. Why CBD stone doesn't give rise to this colic? What gives rise to this pain? Because of the contraction against the obstruction. What is needed for contraction?
Smooth muscles.
Smooth muscles. So CBD does not have smooth muscles. This is the tubular structure. It doesn't have smooth muscles. So CBD stones cannot give rise to a colic. Biliary colic is mainly when the stones are in the gallbladder. Right? Especially when it is stuck at the Hartmann's pouch and the cystic duct. Cystic duct has smooth muscles. Gallbladder has smooth muscles. But still it is not a true colic. Right? But don't think CBD stones give rise to a colic. No. It doesn't have smooth muscles. So that is the pain. What are the relieving factors? Aggravating factors to biliary pain. Meals is aggravated by fatty meals pain. Paddy. Some people they don't have this pain, but they have other dyspeptic symptoms like regurgitation, bloating, flatulence, all these things. Most of the population have these symptoms, but don't think it is a you have to exclude gastric pathology, those dyspeptic symptoms, than the biliary pathology. If patient has dyspeptic symptoms only with gallstones, we can't directly attribute gallstone due to the dyspeptic symptoms. We have to exclude gastric pathology and then only we can attribute those two. Most commonly it is due to gastric pathology. So there can be dyspepsia. Okay, what are the other things that you can ask for the pain? Associated with vomiting, most likely. Now before we go into the history, lesson things, we'll recall anatomy. How are the anatomy distinctions? Who has anatomy distinctions? Not till this two. How many anatomy distinctions? Exception. Complex 40, complex 50. Maybe the right complex part. Last is how we so this is Seriously, I pay not done for very cheap, but I did arts. What is the guitar for that? So this will be really tricky. Pancreas. The gallstones are here. What are the types of gallstones? Cholesterol, big stones and mixed stones. So we'll think about the possible outcomes or sequelae of having gallstones. One thing, having gallstone can give rise to pain. That is called biliary colic. Especially when it comes and last is Hartmann's pouch. Right? Biliary colics. Right? Any other complication? Think about whether there are gallstones in tumbler flow. Can this get acutely inflamed? What do you call that condition?
Cholangitis.
Acute calculous cholecystitis. Right? Is there acalculous cholecystitis? When do you get it?
Ischemia. Hypertension, ischemia.
Stress, like the patient who is having exam stress, final year.
Ischemia. Ischemia.
Those who are in
sepsis.
more than that, HTU and ICU cases, multi-organ failure because of the dehydration and sepsis and everything. Acalculous cholecystitis. If you compare calculus versus acalculus, which has higher mortality? Acalculous. Why? Not because of gallbladder. Because they are at a bad wicket anyway. Mortality is higher in that group because they are on a bad wicket, bad pitch. They are in ICU. ICU is coming in because of multi-organ failure. Right? That's why they are a bad figure. Right? Okay. So that is acute calculus cholecystite. Any other complication?
Cholangitis.
If you don't treat acute cholecystitis properly, what are the other sequel? What are the sequel of acute inflammation? Pathology. Who has pathology distinctions? You have a pathology distinction. Right? Anyone? Anyone who has pathology distinction? Pathology distinction. Yes. Anyone else? Jaundice. Very good. Anyone else? After
Tawin na.
Kalpani. Yes. Pahai. Karat.
Prasadit yun.
Lecturer.
Prasadit.
Yeah.
Prasadit.
So I'm going to ask pathology, all pathology questions from this. The road answer I am going to call Dr. Isha Premki. He's a friend of mine, so I call him. So, what are the sequel of acute inflammation? Yes, already. Acute inflammation. What can happen to acute inflammation? Huh? Acute inflammation is sequel of
Cholangitis.
resolution, abscess formation, chronic inflammation, fibrosis. If you apply the same principle here, you know there's a reason why we have clinical, paraclinical, and preclinical, paraclinical, and clinical in the curriculum, because that knowledge is needed for the clinical. නැත්නම් කෙලින්ම ආපදාස් නම් මේ සබ්ජෙක්ට් හතරක් දැම්ම නම් හොඳට විදිහට අර වඩුවගේ පුතා වඩුවගේ පුතා වඩුවෙක් වෙනවා වගේ පුරුවා දැන් පටන් ගන්න වඩු කර්මාන්තයෙන් දකින්න. ඒ වගේ පටන් ගන්න නම් සර්ජරි මෙඩිසින් ජීනස් පීඩියාට්‍රික් දක්වනවා you are masters by now. But there's a reason why curriculum has preclinical, paraclinical, and clinical, because your chronic knowledge is important. Right? So those sequelae can be applied to acute cholecystitis. So forget about the resolution. What is the abscess here? What do you call that?
Empyema.
Empyema we call that. So what is the difference between empyema and abscess? What is the difference? Empyema is collection of pus in a pre-existing cavity. Abscess is collection of pus in a newly formed cavity. If I get a collection of pus here, it is an abscess. If I get a collection of pus in my pleural cavity, it's called empyema of the thorax. If I get a pus collection in my renal cavity, it's called pyonephrosis. Or is also empyema, sort of empyema. Right? So empyema is collection of pus in a pre-existing cavity. Abscess is collection of pus in a newly formed cavity. So you get the same sequence, but here you call it empyema of the gallbladder. So if you don't treat this acute cholecystitis as an empyema, what is the further sequel?
Mucosal.
No, mucosal is something else. So gallbladder is not gangrenous, then it perforates. So that is the sequel. Acute cholecystitis, sometimes it turns out to be empyema, sometimes it gangrenous and perforates. So that's one sequel of having acute cholecystitis. And there's another one called mucosal. When do you get a mucosal? When there is a stone obstructing the cystic duct. So the gallbladder contracts and secrete mucus, but it is not empty. So there is a mucosal. That's another sequel, mucosal of the gallbladder. Anything else?
Cholangitis.
Still we are here. But now stone is here. Okay, now stone is here. Now what are the sequel now? What do you call this condition? Having what do you call CVD stones? What is that condition called? Choledocholitis. Choledochol is CBD or bile. Choledocholitis. Right? Choledocholitis. So what are the sequel of choledocholitis?
Ascending cholangitis.
One is obstructive jaundice. The other one is cholangitis. So what are the features of obstructive jaundice? 4 features: jaundice, dark urine, pale stools, pruritus. Patient may or may not have all 4. Generally they have these 2, pruritus and Painless stools, it has to be long-standing obstruction. Painless stools also you have to ask the patient, you know, how to how often you look at your sheet? I don't. Sometimes I do, sometimes I don't. So you have to specifically ask. So you have to ask when that heart are doing again. Department one, treatment department, they will say no, unless it's really, really significant. Only you can come up with that answer for the first question. If you dig into the question, they will say yes, when the heart are doing again. Part are doing again. True writers again. What is the reason true writers? Deposition of?
Bile
So that is true writers. So those are the cholangitis. What are the features of cholangitis?
Charcot stripe. Charcot stripe.
Charcot triad. Charcot triad. CHAROT apostrophe. So what is the triad?
Fever, right hand side pain.
Fever with chills.
Right hand side.
RHC pain, jaundice. So this is cholangitis. So that is the sequel of this. And we forgot to discuss about the clinical features. One other acute cholecystitis. What is the presentation? Again, epigastric or RHC pain, typical epigastric pain. May or may not have a radiation to the back, cholecystitis. It's an inflammation. What else they have? Systemic signs. What are the systemic signs?
Yeah.
Fever. What else? When they acute, can they eat? No, they have lots of appetite. They have lots of appetite. So in a patient with gallstones coming with epigastric pain or RHC pain radiating to the back, associated with fever, vomiting, and loss of appetite. And on examination, whenever is sign positive, it is acute cholecystitis. In a patient with stone disease coming with acute cholecystitis, you have started on antibiotic, but despite of antibiotic, they are having high spiking fever. What does that indicate? You have started on antibiotic, you have made the antibiotic process correctly, but despite of antibiotics, if you look at the fever chart, they have high spiking fever. If you get this picture, what are the possibilities? Either your antibiotic is resistant, okay, or there is some sort of suppuration. If you are giving antibiotic, despite of that antibiotic, if there is ongoing spiking fever, that means there is suppuration. So what is the suppuration here? M5 on the gallbladder. That is the time we are suspecting M5 on the gallbladder. Okay? You have to get a scan done. Scan is highly sensitive. Scan is diagnostic and therapeutic also. I will tell you those things later. Right? So you can diagnose M5. In a patient with gallstone disease coming with obstructive jaundice and abdominal pain, it is called painful jaundice. You will think of these are CBD stone. In a patient with obstructive jaundice coming with fever, with chills, you are thinking of cholangitis. Again, you think of CBD stones. Because if it's a malignant obstruction, usually they don't present with cholangitis. Remember that. Usually, they are not 100%. There is nothing 100% in medicine. If patient has a malignant obstruction, obstructive jaundice, generally they don't have fever at presentation because there is no nidus for infection. Whereas if the obstruction is due to a stone disease, they have fever in the history. So if you get a patient, like a young patient coming with obstructive jaundice and have cholangitis in the picture, you will think of stone disease than a malignancy. Because the stone is a nidus for infection. They can have cholangitis. Whereas malignant patient develop cholangitis once we intervene. We do ERCP and then they develop cholangitis. This is general rule. Does everyone understand? You understand what I'm saying? Huh? They are actor not. They are okay. Right. So that is correct. So what are the other C equivalent? So you can come create it out. This is how I remember, the C equivalent, because there are C equivalents when it is here, there are C equivalents when it is here, there are C equivalents when it is here, there are C equivalents when it is here. What is the C equivalent when it is here? Pancreatitis or gallstone pancreatitis. We discuss about pancreatitis later. So we will do gallstone pancreatitis. That is good. What is the other C equivalent? Where it is in the bowel?
Gallstone
IBS. How does it come to the bowel?
Fistula.
Can gallstone pass through the ampulla, cause obstruction to the bowel?
Fistula.
No, because it is too small. Right? So if the patient has gallstone IBS, that means patient has polycystoduodenal fistula. Fundus of the gallbladder almost on the D1, almost on the first part of the duodenum. So if there is a large stone at the fundus, if it is resting on the D1, with time it can erode and creating a polycystoduodenal fistula. That stone is large enough, it can pass through the jejunum ileum and block the ileocecal valve and can present with features of intestinal obstruction. That is called gallstone IBS. So in a patient with gallstone, I haven't seen patients yet. In a patient with gallstone IBS, there's a classical triad that is called Rigler's triad. Rigler's triad. If you get abdominal X-ray, obviously it shows what? Features of intestinal obstruction. Dilated small bowel loops. Small bowel loops. How do you identify small bowel loops in X-ray? Complete rings. Not paired. Valvular polyventus. What do you call this appearance? What do you call this appearance? Yeah, stack of coin appearance. If you see this is jejunum or ileum? Jejunum. Ileum is on X-rays rather featureless. You are sure it is not large bowel, you are sure it is not jejunum, but you see something dilated, it is ileum. Ileum is featureless. You will see these things within next 2 months, don't worry. You will see almost all the cases abdominal complaint of occlusive arterial disease, because we don't have a vascular surgeon in this unit. All the other patients you will see. You will get occlusive arterial also, but that is the least common case here. So in abdominal X-ray, you will see dilated small bowel loops, number 1. Number 2, sometimes you can see the gallstone at the RIF, opacity in the RIF. If it is seen on X-ray, opacity at the RIF, that is the stone that is causing the obstruction. Number 3, when there is a polycystoduodenal fistula, the air enters into the biliary tree. If you get X-ray, abdominal X-ray, can you see the biliary tree in a normal abdominal X-ray? But if the patient has polycystoduodenal fistula, there is aerobilia. So you all can Google search Rigler's triad and you will see X-ray of all 3. Right? Rigler's triad. Rigler's sign is something else. Don't get mixed up. Rigler's sign is something else. We will discuss that later. Rigler's triad is for gallstone analysis. I haven't seen patients yet. If you are lucky enough, you will get it. Okay? So these are the sequelae of heavy gallstone disease. Okay? So we go back to the history. So you can start and you can ask elaborate your proceeding complaint. And if you think it is gallstone disease, you have to ask whether this patient had a past history of these. Because if the gallbladder is not removed, patient get recurrent episodes of one of these. For the same thing again and again. That's why we do remove the gallbladder, because recurrence rate is quite high. So in a patient who comes with epigastric or RNC pain, mainly epigastric, or present with biliary colic, you have to ask, පෞගේ කාලේ මේ වගේම කැක්කු වෙලා හොස්පිටල් එකට ගිහලා තියෙනවා. ඊට කලින් කැක්කු ඇවිල්ලා උණ හැදිලා වමනකින් ඉස්පිරිතාලේ ඇඩ්මිට් කරලා ඇන්ටිබයොටික් දෙන්න වෙලා තියෙනවා. ඉන්ජෙක්ෂන් දෙන්න. that is polycystitis. mucociliary candidiasis. ඔයිට කලින් ඇස් පහ වෙලා මුත්‍රාතද පහ පාටලා ඉඳලා තියෙනවා. ඔයිට කලින් ඇස් පහ වෙලා උණ ගැහිලා වෙවුළු නෑරන් තියෙනවා. ඊට කලින් බඩේ කැක්කුම ඇවිල්ලා තියෙනවා. දැන් සතර කැක්කුමක් ඉස්සරහට පාත් කරලා කඩු වෙන කැක්කුමක්. So you have to touch each and everything. So the reason that I taught you this part, at the end of the history of the presenting complaint, you have to include each of these complications. May or may not be positive, but you have to tell. These are important negatives to say. You will understand? Everyone? Anyone has question? No. So there is name. Okay. So then comes your other histories, past medical history, past surgical history. I generally don't like person controller. Okay, eye contact in money. You have to have the eye contact with the examiner. Now use key or not? Use key or not? So have the eye contact. Those things matters. Examiner बाहर इतना हो गया ना. Examiner के लिए ना पिछले पासे बीती दिया वाला है पता है. Done examiner है या कैसे दिया वाला है ना पिछले बीती वाला है. Examiner दिया वाला है बाहर ना मांगे तो उस was scared. Just look at the wall, concentrate on the wall, right at the back of the exam. Okay. So answer is balan. And man kya then subheadings kiya like past medical history, news kiya then we just work, then we data work again. Story का क्या क्या है? You can say this patient is a diabetic patient. Good that you elaborated. This patient is gestational diabetes. Now one met for me, but better to have having a good control. Don't just stop by saying this patient is a diabetic. Whether this patient is on regular drugs, whether he's in good control, you have to say. Not all the complications of diabetic like in medicine history, but a bit more. Just elaborate if there is any complication. Okay? And the rest of the things are okay. So that's how you take your history. Okay? How do you investigate? Just tell. If this patient comes to you, how do you start your plan your investigations? Just forget about the ultrasound scan. She has not undergone any ultrasound scan. She comes with acute onset of severe abdominal pain. You are the house officer. So it's acute abdomen. What is acute abdomen? Sudden onset acute abdominal pain requiring casualty surgical abdomen. Casualty surgical admission is acute abdomen. That's the definition. Sudden onset severe abdominal pain requiring casualty surgical admission. Acute abdominal pain. So what are the, just forget about this part, what are the differentials, what are the broad categories that you can think of for acute abdominal pain? Acute abdomen, what are the causes? Huh? Yeah, inflammation. It can be acute appendicitis, it can be acute cholecystitis, even it can be acute pyelonephritis. Inflammation. Anything else? Obstruction. Intestinal obstruction, urinary obstruction. Okay. What else? perforation. What are the perforation? Common perforations? Peptic ulcer perforation or gastric perforation? Diabetic perforation. Anything else? Anything else? Anything else? Inflammation, obstruction, perforation, infarction or ischemia. Ischemia. What is ischemia? Concentric ischemia, like a severe abdominal pain. One patient with, let's say, a mural thrombus. Coming with concentric ischemia. Anything else? Anything else? Anyone? Bleeding. One was bleeding. Abdominal or bleeding? Yeah, triple A. Abdominal aneurysm rupture or concealed hemorrhage. What else? This other category called non-specific abdominal pain. It's also, remember, it's ICD-10 diagnosis. You know there's ICD-10. So that is also, but don't give this diagnosis for each and every patient, okay? This is a diagnosis for exclusion. You have to exclude everything to say it is non-specific abdominal pain after extensively investigated. So if somebody asks, examiner, what are the causes of acute abdomen, don't start by saying you will fail the exam. But remember, there is a ICD-10 diagnosis for non-specific abdominal pain. If you will know, you will find a lot of these. Okay. So, if you get a patient like this, I will modify the history. Patient found is severe surmounts of epigastric pain. What are your differentials now? How old is she? 37. So what are your differentials? Peptic ulcer disease. Epigastric. ठीक है, मतलब structures in epigastric. Stomach के बाले में क्या? Stomach पेट के में क्या? Pancreas, acute pancreatitis. How was that? Biliary colic. Anything else? Port 17. Inferior MI, acute MI. Right, so those are differences. Sorry? GORD. GORD got pain and numbness, severe burning sensation, regurgitation. So those are the main differentials. So what, as a house observer, what are the investigations that we will order in a patient who comes with acute abdomen, especially epigastric? Patient needs ECG. Okay. Patient needs serum amylase. Patient needs chest X-ray. Right. Chest X-ray. Right. Those are the three investigations that we will know. We will order all three investigations. Chest X-ray right to see gas under diaphragm. Amylase. ECG to exclude acute abdomen. So those three are needed. Let's assume for ECG, amylase, chest X-ray right to normal. What are other investigations you are thinking of? Because his pain increase after meals. What is the reason why it is increase after meals? Pain, biliary pain. Because of fat in the duodenum. Okay. So what induces covalent contraction?
Cholecystokinin.
Cholecystokinin. CCK. So that causes, those are called collagogules. There are two things, secretagogules and collagogules. Contract the gallbladder and secrete bile. So because of that, they get pain. So you are thinking more in favor of biliary disease. So what are the other investigations that you will order in this patient? Does she have fever? No. Okay. Anything else? But you said she had transient episode of what? Jaundice. What else you will order? Only serum liver function, liver profile is a better term. Why liver function is not good term? What are the liver functions? If you want to see liver function, you will do albumin and INR. Those are the actual liver functions. So it's a misnomer. So its better term is liver profile. So liver profile. See that you will ask for AST, ALT, bilirubin, total and the direct, ALP, gamma GT. So liver profile is a better term than liver function. So misnomer. Okay. If you think that patient has evidence of infection, polycystitis, you can also do full blood count and inflammatory markers, full blood count and CR. So those are the investigations that you will order. Depending on the patient, if you think it's a phalangitis or obstructive jaundice, patient needs IMR and also baseline renal functions. If it's a pure and simple biliary colic, patient needs a liver profile and maybe ultrasound scan. If you think patient has infection or inflammation, patient needs full blood count and CR. If patient has evidence of obstructive jaundice, patient needs a liver profile. If patient has phalangitis or obstructive jaundice, patient needs INR, renal functions, because obstruction can lead to renal impairment later. So you need to have your baseline investigations. So depending on that, you investigate. Right. So those are your basic investigations. Imaging. What are the imaging that you will order? What are the basic imaging? Ultrasound scan of abdomen. Now, final year, when you say investigation and say what you look for. Now, there's a difference. One student can say, I will do ultrasound. Just wait. Then examiner has to ask, what are the things that you will look for? Repeated questions. Prompting. That patient will pass but get minimum marks. The person who answers spontaneously without letting the examiner speak will get more marks. So I will do ultrasound scan of abdomen. Will you do it without fasting or with fasting? If you want to visualize the biliary tree, you will do it with fasting or without fasting. Because after meals, it contracts. You will not see the actual biliary tree, proper diameters and everything. I will do ultrasound scan of abdomen with at least 4 hours of fasting to visualize biliary tree, to see gallstones, which is a very much sensitive investigation, ultrasound scan, to see the gallbladder. Any radiologist can see. And also to see evidence of either direct or indirect evidence of CVD stones. What is the direct evidence of CVD stones? To see a stone. If ultrasonographer says she or he has seen a stone, that means there is a stone. If ultrasonographer says no CVD stones not seen, can we exclude? No, because ultrasound is not a very sensitive investigation for CVD, especially for the lowermost CVD. CVD has 3 parts. CVD has 3 parts: supraduodenal, retroduodenal, and intraduodenal. The intraduodenal part is retropancreatic. Pancreas is not. Pancreas itself is a retroperitoneal structure. Imagine pancreas is not may part again. So it's very difficult to visualize. So I will do ultrasound scan of abdomen with 4 to 6 hours of fasting to visualize the gallstones and also to see evidence of CVD stones. Direct evidence is seeing the stone, indirect evidence is tap dilation. Tap dilation, CVD. What is the normal diameter of CVD? Oh, 6 to 7 millimeters by the age of 40. For every decade, it increased by 1 millimeter. After 40. Up to 40 years, it's about 6 to 7 millimeters. Every decade, it increased by 1 millimeter. So, if it's a 70-year-old, what is the diameter? 1 centimeter may be normal. Why I say may be normal? If the patient has obstructive jaundice, 1 centimeter CBD normal and had diagnosis. If it is clinically significant, you have to investigate. But remember, 1 centimeter could be normal for a 70-year-old, but not for a 40-year-old. Okay. So that's why you do ultrasound scan to investigate for CBD stones. That's a preliminary investigation. Any other investigation with regards to biliary? Am I too fast? Or you want me to slow down? Yeah. I don't like silent groups, okay? May follow it out. There's a yeah, the exception in the sound.
Yes.
Sir? What about ERC? What did they say about ERC? Is it a diagnostic investigation? Huh? You don't use it for diagnostic purpose only. Why? It has complications. So don't say ERCP. You don't do it for diagnostic purpose. So if you don't have direct evidence of having CBD stones, like cholangitis, obviously you know that patient has CBD stones. Patient has cholangitis. If ultrasound says CBD stones are seen, it is a direct evidence. If you don't have the obvious evidence of having CBD stones, you have to go for another investigation. What is the other next line of investigation? MRC. MRC. What does MRC stand for? Magnetic resonance electromagnetic. It has about 98% sensitivity to see the ghost stones, CBD stones. Even up to 2 millimeter stones can be seen MRC. It has about 98% sensitivity. But do we have this investigation in our hospital? No, we don't have MRI. But before you are finished your profit, you will get MRI on the way. Super giver hoga. No super नहीं. Super super. Yeah, राजी था यार. Super है only problem is in the government sector we don't have it filed. Currently we have the National Hospital, Anuradhapura, Karafitia, Kandy. The 4 station in Sri Lanka have it. So what is the other investigation? What do we have here? Contrast and CT scan, but sensitivity is not as great as MRC with regards to CBD stones. Right? If you don't have the very strong indications having CBD stones, you can go for MRC and then proceed. Okay? So those are the investigations. So this is how we investigate a patient with suspected biliary stones. Any questions up to now? Any questions? You all understand what I mean or sounds Greek? Barium we don't do it. How much time because barium is out of stock in Sri Lanka. Barium meal is to see the stomach. Barium has nothing to do with this. Earlier days there was a scan called HIDA scan. HIDA. But HIDA is also we don't do it. To diagnose acute cholecystitis is also HIDA. Hepatico-immunodiacetic acid scan, HIDA scan. Now we don't do it. These are the investigations. ඔන්නමයි කාලා දෙන්නේ. දැන් මේ බුද්ධිමතද තියෙන්නේ. කන්න කලින් ක්ලාස් එක නේද? ඇනුත් යනවා. ඇනු යනවා. මට ඇනු ගිල්ලොත් වාතයෙන් පිට වෙනවා. No one has much equipment, but keep your hand like this anyway. Makar kata dia hoy. Manage. All what we discuss is symptomatic gallstone disease. Symptomatic. That means there's a category of asymptomatic gallstone disease. So what is the management for asymptomatic gallstone disease? Conservative. I will include another term. Expectant management. What is the difference between your conservative management and expectant? Conservative means patient is symptomatic, but you don't want to do a surgery. Either patient is too old or not fit for surgery, or you are trying to manage conservative. Expectant is patient is totally asymptomatic. You don't trouble the trouble until trouble troubles you. Right? You leave it alone. So that is expectant management. Right? So asymptomatic gallstone disease, the treatment is expectant management. Just because you find a gallstone in the scan, don't offer him or her polycystectomy. Right? But there are instances where we do polycystectomy for asymptomatic gallstone disease. There are instances you get MCQs. One is if the patient is having poorly controlled diabetes. These are not what do you call it, definitive indications. These are not absolute indications. These are relative indications. There are relative indications to do polycystectomy to patient with asymptomatic. One is patient has poorly controlled diabetes. Because one reason is if this patient has one complication or symptomatic, that complication could be a disastrous or detrimental complication like acute polycystic because the immunosuppressed because glycemic control is not good. So you can offer. That's one indication. Another indication is patient with hemolytic anemia. Why? Because they are having excessive hemolysis, there is a possibility of pigment stone formation and later sequelae. None of these things are absolute. Another one is those who are awaiting transplant. Because we do transplant surgery, with that we remove the gallstone. Otherwise, you do a transplant and then they will get a complication of gallstone. Those who are awaiting transplant also we remove. But these are relative. So you will get MCQs on indications for asymptomatic gallstone disease polycystic. So generally it is expected. Symptomatic patients can be managed medically or your conservative and surgically. What is your medical management? Those who are not fit for surgery can be managed with medical management. Low fat diet. Fat content symptomatic or very low fat diet. Stones दिए करा क्या लगे? Gallbladder stones. There's a possibility you can use.
Chenodex.
Folic acid.
Biosol.
Folic acid. Folic acid. Oral. That is your medical management. We have to offer them polycystectomy or removal of gallbladder. This can be done by two approaches, open and laparoscopic. Currently, the standard of care is laparoscopic polycystectomy. Standard of care is laparoscopic polycystectomy. First lap poly was done in 1985 by a German surgeon called Erich Mohr. Sri Lanka it was introduced 90s. The standard of care is laparoscopic cholecystectomy. Is it a risk factor for gallbladder cancer? Yes, it is a risk factor for gallbladder cancer. Having said that, then you can ask, why don't we do asymptomatic? Because if it is a risk factor, even if it is asymptomatic, remove. Because the incidence of gallbladder cancer is very rare compared to incidence of gallstone disease. That means it is not a significant problem. So there is the possibility of dying from surgery is way much higher than possibility of dying from very rare cancer of gallbladder. So that's why we don't offer cholecystectomy just because it is a risk factor. You all get my point? Huh? So you don't offer because of that. Although it is a risk factor. Having gallbladder stones is a risk factor for gallbladder disease. Because it can cause chronic cholecystitis. Chronic cholecystitis is a risk factor for gallbladder. Pathological. What is the pathological feature of chronic cholecystitis? What do you see in that is a risk factor. But what do you see in histologically? What do you see in chronic cholecystitis? Rokitansky, Ashkoff.
Hey, gold. Koranji pass now. Koranji pass
Right. Okay. So surgical treatment, before we go to that part, we will think of management of each and every condition. Biliary colic, what is the management? If patient comes with abdominal pain and you have diagnosed, you have made the diagnosis of biliary colic. What do you manage? How do you manage? Patients come because of pain. How do you manage? Painkillers. Okay. And then, on discharge, you offer a patient that colon. That was cholecystectomy. That is the management plan. Okay? Acute cholecystitis. How do you manage? Does she need admission? Cholecystitis? Yes. Most of the time, yes. If it is a mild attack, you can manage with oral antibiotic, but generally they need admission because they are having loss of appetite, they are vomit, they can't, so they may be dehydrated, so you have to admit. Right. Do they have pain? Yes. They need painkillers. Very simple, very simple. You are obvious. How do you manage? You start your answer. If you try to organize your entire answer and then answer it, you cannot. You start answering. How do you manage? These patients have come so I will prescribe painkillers. You start your answer. Then something will come to your mind. Painkiller. What else? Yeah, you have to start them on IV antibiotics. It depends on unit policy. We generally start them on IV cefuroxime and IV metronidazole. Some people give IV ciprofloxacin. So IV antibiotics. Do they need saline? Yes. They are vomiting, they are dehydrated, they have loss of their kidneys, so you have to give IV fluids. What else? They are vomiting. You have to give anti-emetics. They are having infection, right? So then at the same time you have to send all the investigations. Investigations together. Full blood count, CRP, renal functions, liver profile, everything you have to send. I'm not talking about investigation. These are only for the management, but management always includes. Management means investigation and treatment. Management. So you have to investigate also. I'm not touching that part. You can't just list out your treatment plan without investigating. So this is for a diagnosed patient, acute cholecystitis, I'm telling the management. Admit, the painkillers, IV fluids, antibiotics, antiemetics, You can also start them on IV ranitidine because they are very much stress. To prevent stress ulcers, you can start them on IV ranitidine. Okay, what else? And then maintain an input-output chart. They may have dehydration. If they have comorbidities optimized, like those who are having diabetes, with the infection, their sugar levels are very high. So you can manage their diabetic level, sugar control. So that is the management of acute cholecystitis. Once the acute condition settled, you have to offer them what is this patient? Symptomatic or asymptomatic? So what is the treatment? If they are medically fit, they need cholecystectomy. So later you offer them that. There are two things here. Lap chole can be done at the acute setting. That can be cholecystectomy can be done at the elective setting later. Acute cholecystectomy is called hot cholecystectomy, not because the patient is hot or the nurse or the doctor is hot, because you do it at acute setting. That is called hot cholecystectomy. So if you do the cholecystectomy within 72 to 96 hours, that is within first 3-4 days, there are advantages of doing this. Some people do it, but our unit policy is not such. But there are units which practice this policy, they do hot cholecystectomy within the same episode. There are advantages. One thing is, there are no additions are less, because addition takes some time, right? So additions are less. If you do it very early during the first episode, additions are less. And there is the inflammatory tissue fluid. If you get a scan done also, scan says pericholecystic fluid around. That's a sign of acute inflammation. So this pericholecystic fluid or inflammatory fluid can be used as a dissection medium for dissection, for surgery. That's another advantage. Another major advantage is, if you offer this patient later cholecystectomy, during this waiting period, can she get another attack? Yeah. It reduces the recurrent episodes and recurrent hospital admissions. That's another advantage. If you do the cholecystectomy at the same setting, it's just one admission, one stop, cholecystectomy, discharge, no gallbladder. Again, coming to the clinic to see the gallbladder histology only. Whereas you manage the cholecystitis, discharge the patient, and do the cholecystectomy in 6 weeks. Within this next 1.5 months, patient can come with biliary colic, another acute cholecystitis, so on and so forth. Therefore, it reduces the repeat hospital admissions and repeat episodes. Those are the advantages of hot cholecystectomy. But one disadvantage is, when we call hot cholecystectomy within first few days, first 4 days, from the onset of symptoms. Sometimes we come across a patient, we think it's hot, but it is not hot. Like in general life, hot is hot man, 1 or 2. That is not a sexist comment. So hot cholecystectomy. They can patient දවස් දෙකක් තුනක් ගෙදර ඉඳලා කැක්කමත් එක්ක. අපිට ආපු දවසේ නම් පැය 72ක් කියලා ගන්න බෑ. From the onset of symptoms. So if patient is at home with abdominal pain, කොහොමද දතකාවේ ඉඳලා අපිට ඇවිල්ලා බලනවා අච්චර ඇතුළට ගිහින් බලනවා hot නෑ. Additions ඇවිල්ලා we are doing it in hot stage to get the advantage of not having additions. But if we skip this window period, there are additions. Sometimes the transverse colon stuck to the gallbladder, sometimes the duodenum stuck to the gallbladder. So these are hot cholecystectomy. Elective is after 6 weeks. Some unit practice cholecystectomy in between also. But this is the general principle. To do it at acute setting or do it later. You know the pros and cons. During later, why are we delaying for 6 weeks? Thinking that additions will settle. සති 6ක් කරනවා additions ආපුවම settle වෙයි කියලා කරනවා විතරක් ඉන්නේ. But during this waiting period, patient can get repeat episodes. So this is in a patient with cholecystitis. next scenario. While you treat this patient with IV antibiotic, patient develop high spiking fever. High spiking fever. What do you call that? You suspect M5 of the gallbladder. When you suspect that, what is the investigation of choice? Not only high spiking fever. If you do the WBC count, it's going up. Yesterday it was 12,000, now it's 19,000. That means patient is not settling. CRP yesterday 100, now it's 300. So your inflammatory markers are going up. Patient having high spiking fever, you are suspecting a suppuration. That is M5 of the gallbladder. You get an ultrasound scan back, which is a very sensitive investigation for M5 of the gallbladder. And I told you it is diagnostic and therapeutic. What is the treatment for abscess? Drainage. What is the treatment for M5? Drainage. So if it's M5 of the gallbladder, patient needs drainage. Not a simple IND, gallbladder couple in there. You have to drain the gallbladder. There are so many ways of doing it. You can do it ultrasound guidance. Ultrasound guidance. Percutaneous transhepatic cholecystostomy. Stomy means open. Stoma means you open. Mouth. Mouth can stoma. Cholecystostomy. And gallbladder percutaneous transhepatic. Percutaneous, that's some guided. Through the liver, we come to the gallbladder and drain it. The advantage is tubular discharge chance good up. There are two things now. You have liver thing, you have gallbladder, you have abdominal wall. We can come to the gallbladder, percutaneous transhepatic. That's one type. We can come to the gallbladder, percutaneous persistent. Brains the විදියට දාන්න. මෙහෙම දාන්නත් පුළුවන් මෙහෙම දාන්න. Which one is more secure? Obviously this has some behavior. Whatever you learn, I think it's more secure. That's one advantage. Transverse dislodging this brain is less compared to this. Even if it's dislodged, where will the bile leak into? Will it leak into the peritoneum? No. So minimal bile spillage, even if it dislodges. Whereas if it is here, dislodging chance එකක් වැඩි. මේක ගැලවුණොත් bile පාට leak වෙනවා. Peritoneum, within peritonitis. So that's the disadvantage of this strain. So එහෙම කියන මෙහෙම දාපු brain එකක් ගලවන්න බැරිද? After 7 to 10 days, there will be a granulation tissue tract. Make whatever tract after 7 to 10 days. So you can remove it. So bile will leak through this tract into the skin. Right? So even if you want to remove it, you keep it for about at least 2 weeks before you remove it, until the tract forms. That is the principle behind it. Okay? So you can do ultrasound guided cholecystostomy drainage. One is percutaneous transhepatic or percutaneous cholecystostomy. If you don't have that facility, you can actually do open cholecystostomy. Open cholecystostomy. So for M5 of the gallbladder, drainage and the ultrasound guidance rarely open. Open facility. Can you do lap poly for M5 of the gallbladder? Yes, you can do one cholecystectomy. You can do. That is also an option. Easy what can do. Let's say you have not done cholecystectomy, you have done only drainage. There was a patient like that. That patient was discharged before that patient will be coming on 3rd. There will be a patient admitting on 3rd of November for cholecystectomy with a percutaneous drainage. So, if we have drained through this method, later you can offer this patient what? Cholecystectomy, because this is symptomatic post-cholecystitis. Patient needs a cholecystectomy. So, end result is if patient is medically fit, patient needs cholecystectomy. Whatever the clinical presentation. In M5, so I told you, I think you were sleeping. What cholecystectomy? can.
What is the training without going straight away?
What's the
Training.
now, that is unit practice. I mean, our unit, we don't do hot cholecystectomy, or we don't do cholecystectomy empower the gallbladder. It's not easy. There is a very high chance of converting into opening procedure, or a very high chance of damaging surrounding structures. So we don't do it. So we train here, we go leisure. Plus, we don't have theatre time. All the other we have theatre time now. Yeah? So in a country where there's adequate theatre time, you take the patient to theatre straight away. We don't have it. What is the next sequence? CBD stones. Or polydoccolithasis. 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 They can present with obstructive jaundice, with or without cholesterol. That is presentation. Investigation I am not going to discuss, we have already discussed. Treatment. How do you treat? Does he need admission? If it is just obstructive jaundice, but if patients cholangitis, obviously needs admission. Right? What else? If they have pain, you give painkillers. What else? Do they need antibiotics? Yes, cholangitis needs antibiotics. After blood culture. These patients are really ill, cholangitis patients. Extremely ill and very high mortality also. And if patient has no vomiting, you can of course feed, no problem. There is no indication to keep the patient ill by vomiting. As long as patient can tolerate feeding, no vomiting, as long as pain does not increase after meals, you can ask them to. You initially start them on liquid diet. If they can tolerate, they can have a soft diet. If you really got kind of bad, your pain will get worsened, but you can have a light soft diet as long as they can tolerate it. Right? So give IV antibiotic after blood culture. They need IV fluids. You have adequately hydrated, otherwise they will go to renal failure. And monitor input output chart. What else? Sometimes, if it is elderly patient, you have catheterized and monitor input output chart. If they are vomiting, you have to give IV antiemetics and IV ranitidine to prevent ulcers. So that's how we manage patient with cholangitis. We consider obstructive jaundice. What are the main problems? What are the main complications of obstructive jaundice? This is our final year essay, 2009. That is my final year, 2009. Long time back. What are the main complications of obstructive jaundice? Bleeding. What is bleeding? Any other complications? Hepatorenal syndrome. Ascending cholesterol. These are the three main complications. And also liver impairment and encephalopathy. Long standing, not for samadhi, but in the hand. Malignant obstruction, long standing can develop. There are so many malignant obstruction patients in the world. There is one patient who transferred from Army Hospital, acute side. There is another one patient, Veera Singh, side. So many resources here. Chemical man, resources that are so. I think after the other one, Veera Singh, I think पाँच ही तरफ हो गया था हमारा कौन सा पुस्तक है? Not that I am foresight, I am also against it, but make use of it. There are so many patients here. Those are the main complications of having obstructive jaundice. bleeding. Charmi. She said bleeding is a complication. Why? Your patient with obstructive jaundice. If I ask this question at the exam, how will you answer? How will you answer? Gamma carboxylase then. Gamma carboxylase is needed for activation. Extrinsic part. So what about 7, 2, 9, 10? So intrinsic path is working. Where is the white 9? Where is 9? Intrinsic path. 2 and 10? Common path. So basically plotting is not. Why do we check? What is the investigation of choice in a patient with obstructive jaundice? What does it check? Which path? Extrinsic path. Then common path. So why don't we check the APTT here? Why do we check INR only? General check INR, right? It is a percentage rate, right? Why?
Shortest half-life.
Yeah, factor 7 has shortest half-life. So that's why we go by INR. Okay, good. So that's how the bleeding occurs. Like as she explained, you have to tell from the beginning. When there's obstructive jaundice, bile doesn't come to the gut. And bile is needed for fat absorption, along with that's why the nutrients are not absorbed. Right? That's how we should explain. So, as she said, 2, 7, 9, 10 is gamma carboxylated into activated factors. During this process, vitamin K works as a cofactor. Work as a cofactor. It is converted into 2,3 epoxide. Right? And 2,3 epoxide is converted back to vitamin K by 2,3 epoxide reductase. So as biochemistry is epoxide reductase. Right? So this is a natural pathway. Warfarin inhibits 2,3 epoxide reductase. So this natural conversion is not there. That's how warfarin acts on these factors. I hope you all know that. Right? So you want to give, if you want to overcome the action of warfarin, what is the antidote? Vitamin K. So if you give vitamin K, doesn't matter warfarin, if you give more vitamin K, warfarin action will nullify it. Right? So in a patient who has there is a risk of bleeding, therefore a patient with obstructive jaundice or pancreatitis, with the investigation you have to do based on INR. If INR is deranged, you can do two things. Either you can start them on vitamin K, 10 milligram IV for 3 doses. There is no point of giving beyond 3 doses. It has no action, no benefit. You give 3 doses. But if you want to do something quickly, if you want to correct it quickly, what is the choice? FF. What is the dose of FF? 10 to 15 kilogram per body weight. Right? 10 to 15 ml per body weight. ml per kg. 10 to 15 ml per kg. ml per kg. So that's why you need INR. In the range, this is the treatment. Okay? So with the management, this has to come if it is deranged, if clotting is deranged. Then how do we tackle this further? This is the medical management. This is to settle the systemic inflammation. How do you tackle this further? How do you get rid of these CBD stones? There are several options again. Now the ERCP criteria here now. I can the better group class sometimes we teach individual and both class body theatre what you learn you have to write there the magic word inside. Actually the magic word that is their purpose. For example, what I told today at ERCP, you have to at least write the topics. Yeah, this is what we learned. So those who are interested can come and ask. The group learn. How you do it there? You can't actually magic word that. I mean, you cannot say what. CBD stones, there are several ways. So there is a stone. Can you do cholecystectomy in this patient without clearing this off? No. The reason is this system is blocked. This system is blocked. And if you do a cholecystectomy and clip this and take out the wall bladder, when this is blocked, the intrabiliary pressure goes up. When the pressure goes up, in a cholecystectomy patient, what is the least resistant side? The clip side. The clip will blow out. The clip will blow out. And give rise to biliary peritonitis. Whose patient is that one? Today we did ERCP. Patient is your patient was undergone cholecystectomy and now local hospital. Your patient, you have taken the history. Who's the history part? You have taken the history, right?
Yes.
What does the ERCP finding? What does the ERCP finding? Was not interested to see. Just after ERCP. We have to go how to take you with them. So as you find, because it's a cystic gas stump low, possibly because of this CBD stone. So therefore, because of this fact, we have to clear the CBD either along with cholecystectomy or prior to cholecystectomy. In a patient with CBD stones, before cholecystectomy or at the same setting, we have to clear the CBD. Otherwise, you will come across this sequence. It's not easy because if this starts leaking, patient will develop biliary peritonitis and sepsis and then die. So to prevent this complication, we are clear. So there are two things you can do. Actually, three things. You can do laparoscopic cholecystectomy and at the same time laparoscopic CBD exploration and clear it. But this practice is not much happening in Sri Lanka. We don't have many surgeons who does, I don't know anyone who does these two together. Another option is open CBD, open cholecystectomy, open CBD exploration. Again, very obsolete practice. I told you standard of care is what? Laparoscopic cholecystectomy. So there may be a very peripheral surgeon who does not have access to laparoscopic facility, will do this option. Right? A patient from maybe Pakangudi will undergo open cholecystectomy with open CBD exploration. What we practice here commonly is we clear the CBD prior to cholecystectomy by using ERCP and then do a laparoscopy. This is the commonest scenario that you will come across. If you go to Australia, this is the commonest in Australia. Even in UK, this is commoner than this. This is almost obsolete. Right. Do you understand this now? Why do we need to clear the CBD and the air? Then we think about ERCP. We have several options to get rid of CBD stones. As we discussed before, we don't do it for diagnostic purpose, we do it for diagnostic and therapeutic. When you come for ERCP, you already understand what I am saying now. How do you see CBD stone at ERCP? As it's a filling defect. In the dilated CBD, you will see this as a filling defect. Did you take pictures? Can you share that with you? You have a WhatsApp group or Viber group for your group? Already shared. So you will see that as a filling defect. It's a common of CBD. So you see that as a filling defect. So that you can retrieve by many methods. I'm not going to discuss much about ERCP. I will teach that during ERCP. One is balloon sweeping. Balloon sweeping. You pass a balloon above the stone, inflate the balloon, and then pull the balloon along the stone. That is balloon sweeping. Or you can pass a basket and catch the stone and take it out. Nomia basket extraction. Nomia basket extraction. Sometimes the stones are very much hard. You can't extract. You have to break it. Large hard stones. So you pass a lithotripta. Lithotripta means you break the stones. Lithotripsy means you break the stones. And you pass a lithotripta and break the stones. Mechanical lithotripsy. Another option. These three options we have it here. Another option that we don't have here is laser. Laser. We pass another scope into the CBD and directly see the stone and break it with the stone. We have the scope, but we don't have the laser. The last option. Sometimes here if we can't do these three, for one patient we couldn't retrieve the stone by doing these three today. We put a stent across. There is a stone which cannot be retrieved. What is the purpose of putting this stent? It has two purposes. It serves two purposes. One thing, release obstruction. Obviously, now it's obstructed system because of stone. We could retrieve the stone. We pass a stent alongside the stone. So it relieves the block. It relieves the obstruction. Patient will get better. Jaundice will resolve. And the other thing is, keeping this stent will make the stone friable. Because of the Hollywood reaction, will make the stone friable. So in next attempt, after 1 month, we can pull out the stent and do one of these methods and retrieve the stone. Okay? So these are the options to overcome. This is actually not option to retrieve the stone. These are the options to clear the stones. This is the option to relieve the obstruction. Right? Relieve the obstruction. So ERCP and do one of these things and then do laparoscopy later. Now during this procedure, patient can bleed because we cut the sphincter. We cut the sphincter of body. In a patient with obstructive jaundice, we have to make sure that the INR is normal or if it is abnormal, it is corrected prior to ERCP. Otherwise, patient will bleed to death. Therefore, in obstructive jaundice patient who has a higher tendency to have coagulopathy, INR has to be corrected prior to ERCP because there are three main complications of ERCP. One is bleeding, the other one is duodenal perforation, D2 perforation, third one is acute pancreatitis, post-ERCP pancreatitis. So those are the three main complications. Because all these three complications are very much hazardous. Therefore, that's why we don't do ERCP for diagnostic purpose. We use only for therapeutic purpose. Okay? So that's how we clear the CBD. We do that and then we'll have to. And any patient who is coming for laparoscopic cholecystectomy, we do a liver profile. Any patient who is coming for laparoscopy, we do a liver profile, mainly to see the alkaline phosphatase level, irrespective of whether they are having obstructive jaundice or whether they had obstructive jaundice. If they are having obstructive jaundice, obviously we don't do laparoscopy unless we clear it, as we discussed. We do a liver profile and see the alkaline phosphatase value, ALT value. If the ALT levels are high, we have to suspect biliary obstruction. Sometimes, those who have CBD stones may not be icteric. Now, your patient, is she icteric now? Did she have a CBD stone today? During the procedure, yeah, she had a CBD stone. Right? She had a CBD stone. So, we go by alkaline phosphorus, but her alkaline phosphorus is 500, it's high. Right? So, in a patient with high alkaline phosphorus, what is the investigation of choice? You have to go for a MRCP and confirm the presence of CBD stone, and if it is there, therefore we did this procedure. So, prior to any patient polycystic, we do look at this value and make sure it is normal. Because if it is high, patient needs further investigations prior to polycystic. Because we need this to start blow out. But remember, there is about 5% of population who have CBD stones with normal alkaline phosphatase. එයාලා බලන්න විදියක් නැහැ. මෙහෙම කියලා හැමෝටම MRCP කරන්න ගිය MRI වලට යන मैडम ईमेल में सारी आप पुस्तकें मुलाकात लैप्टॉप के MRCP हो गया to catch this 5% of the population. Because if alkaline phosphorus is high, obviously you can confirm. But if it is normal to catch this 5%, we don't do it first. We take the chance. Some of them become symptomatic after lactose. Then, before the stump blow out, quickly do a ERCP and put a stent. So, you all understand management of CBD stones? Gallstone pancreatitis, I will discuss the management later with the pancreatitis. I am not going to discuss management of pancreatitis. Management of gallstone pancreatitis is, what is management? Do they need lap poly? Why not? Why? There are symptomatic gallstone pancreatitis. Yeah, obviously they need lap poly. Question is when? How does it happen? I'm not going to discuss management or the categorization. If it's a mild acute pancreatitis, patient needs lap poly at the same admission. Same admission. If it's a moderate to severe, later. So gallstone pancreatitis patient also needs lap poly. Question is when to do it. If it's a mild acute pancreatitis, do it in the same admission. If it's a moderate to severe acute pancreatitis, do it later. The reason is, why do you want to do it at the same admission? Because the recurrence rate of gallstone pancreatitis is quite high, about 30 to 50% of them recur. So during the waiting period, they can get another attack. Although this is mild acute this time, next can be a severe. May not be able to go home also. So pancreatitis is a disaster. Pancreas is similar to what? Yeah, I know you don't know the answer. Pancreas similar to what? Similar to who? Right? Similar to a woman. Very unpredictable. We surgeons respect the pancreas very much. Because it's highly unpredictable. Some pancreas, even if we step on the pancreas, some are pancreas in lung here, that is pancreas. So pancreas is equal to a woman, not said by me, it's said by a lot of surgeons, including Professor Mohan. Highly unpredictable. So we respect the pancreas and we go. And to a certain extent go into forms. Because complications are very detrimental. We respect the other organs, but we respect pancreas. So, if it is a mild acute pancreatitis, we offer this at the same admission because the recurrence rate is high. But if it is moderate to severe, although the recurrence rate is high, because it's moderate to severe, we can't offer them with the same admission. You will understand when you do pancreatitis, what happens in moderate to severe pancreatitis. They are not fit for a general anesthesia and cholecystectomy, right? Because of the organ dysfunction. Therefore, whether we like it or not, we have to defer it to a certain extent in moderate to severe. But in mild acute, the organ systems are perfectly fine. To prevent a recurrent attack, we offer them with the same admission. That is the treatment for acute pancreatitis. The last one, acute gallstone pancreatitis, read about management, I don't know. I think you have to manage intestinal obstruction. Just read about it. Exploration
and the cholecystectomy and the ARCG and then doing the cholecystectomy. Is there any particular complication?
Complication is a single admission. Poly CB exploration, it's a single admission.
Can't do the ARCG and then do the laparoscopy?
Like
same
this?
Day? Yeah, same day.
Same day. Can do, but it's only thing is now there's a risk of post-ARC pancreatitis, right? And you do cholecystectomy, it's also major surgery, not intermediate to major surgery. If patient develop acute pancreatitis, you don't know if pain is due to complication of your cholecystitis or complication of ERCP. So generally we don't do it on the same day. But if patient recovers well from ERCP, of course you can do lap chole on the next day or a day after. If patient recovers well. But patient is undergoing general anesthesia back to back within 2-3 days. You get my point? But generally we don't do it in the same anesthesia because if patient develop complication, මොකක්ද කියලා දන්නේ නැහැ. Especially on top of a surgery, if patient develop pancreatitis, බඩුව තමයි. ඒකින්ද ඒක එකට කරන්නේ නැහැ, but of course you can do it in the same admission. ERCP, let the patient recovers well, don't discharge to laparoscopy. But we don't have theatre time like that. Okay. Other countries they do that. Any questions? No. Extracorporeal shock wave epilepsy is ESWL. Is not for CBD stones. People have tried that method for gallbladder stones, especially when there are stones less than 3 stones. It was a practice. Now it is also almost observed. We offer ESWL only for pancreatic stones and ureteric stones, renal stones, not for gallstones anymore. But it was a practice. It is less effective. It has been tried successfully for stones less than 3. I mean number wise, but not for CBD stones. Of lap chole. Nothing much. So as you see, we discussed those things in the board round. So read about complications of laparoscopic cholecystectomy. Okay. Currently you have to read and let me know. You can divide your complication into 2 parts. First, anesthetic complication and surgical complication. Surgical complication also can be divided into several parts. Complications of surgery and complications of pneumoperitoneum. Complication of pneumoperitoneum. So tell me, you really know about complications of pneumoperitoneum, no? So read about it and let me know. If someone asks about complications of some surgery, you can divide like this, but don't touch on anesthetic complication. So I will just concentrate on surgical complications only and jump on surgical. But for the breakdown purpose, you say like that. May surgery why very large anesthetic complications, especially when there are anesthetists in the surgical line. They get really annoying. Monitor, you have to arrange a class by we start to learn. Mailers for certain things, like stoma and stomach dressings, certain things. And get our RHOs to teach your skills. That's another OSCE station, skill station. And you will have to speak to USRs and arrange GU classes. And plastic surgeon to get to teach your burns and hand infections. So, you try to arrange orthopedic teaching and anesthetic teaching. Try your best to arrange. I'm sure. Okay, any questions? Did you all understand? No, that our meter one dynamic post on here, then an exception in the month. Then an exception can become funny then. I'm not going to tell how we do it. But if I get good at that, I got to it. So I'm looking forward for exceptional results also. Any questions? Anyone? So, we'll discuss about that with malignant obstruction. That patient has a cholangiocarcinoma with external biliary drainage. I tell you why we did it. Painless option. Two really right duct and the left. Bit of complicated case. You all need to know that much, but you all need to know a bit about. Then that patient was given for long case for your 22nd batch. If I wouldn't decide about their performance and long and short cases, I spoke to a lot of examiners. They said long case performance is good because it's theory, but the short case performance was not good. So from the day they start, I told them you have to practice short cases. So I'm telling you all also, do short cases. Do it, trouble us, examine current. Doesn't matter. That's how you should learn. Make a name, earlier you learn. In bad. Do short care as much as you can, especially at clinic. And you all have this CEX form to sign for Amma. So you have to say, I need to sign. Martin step present karana, edam karana, but Bangura, no, Matana, or one will be the other, or if you were. So I have to mark and sign on the same thing. At that over than Oscar Halina, with an echogram, polio, that are Matapain, Potas. Oscar Halina will walk to category size burner, candle size burner, which is a master part to you. It is not a category size schema. Mark and Mega chicken oil.